All right, ladies, so I'm going to be fighting through my head cold here, but I'd like to go ahead and get us started on some more clinical material to go with Unit 5. And so today I'm going to introduce you to the field of radiology, which is a pretty popular specialty in medicine. It definitely appeals to people who are a little more nervous about working directly with patients, because in radiology, you can kind of take different approaches, and sometimes you do interact with patients a lot, and other times you don't really interact with patients a lot. So this does appeal to some people who don't necessarily want to see a lot of people every day. But my hope here is that we can use the anatomy knowledge we've gained through dissecting and apply that to scans of the body. So first, what is radiology? Well, it's a specialty that uses imaging to diagnose and treat disease. So you can use a lot of different imaging techniques, which new ones come out every so often as technology increases. But we're going to talk about just the major types in our class, and we're going to get you guys working with what are really kind of the most straightforward types. So X-ray, or sometimes called conventional radiography, is the number one thing we're going to use because it is, I think, the easiest to interpret for someone who is just getting into anatomy and medical study. I'm sure you guys are also familiar with CT scans or computed tomography, so we'll talk about what that is, and MRIs, which is magnetic resonance imaging. Ultrasound also is something that we'll not really get into much, but that's where you're going to use sound waves to form an image. So when we look for babies, when we need to do scans on babies after they're born, we tend to go with ultrasound because it doesn't really have any negative side effects that we know of. A couple other things that are common but not something we're going to get into is fluoroscopy, which uses these kind of contrast agents injected into the body, or maybe you have somebody drink something before you do scans. And then nuclear medicine, which uses radioactive isotopes, and so this would include the PET scans we mentioned back with cancer and things. But important part kind of to start with here at the bottom is that best practice in radiology is to only ask for the most medically necessary diagnostic exams, because at the end of the day, the majority of these scans do expose people to potential side effects. X-rays and CT scans are radiation, so it's small amounts and it's not something to be scared of, but you don't want to ask somebody to be irradiated for no reason. So if you need a scan, great. If you don't, try to avoid using these when we can. Okay, so a little bit of radiology history. I won't expect you guys to remember this stuff really, so this is not something to study, but I do think it's kind of interesting. So this is Röntgen right here, and Röntgen is sort of the father of radiology. He was the first person to perform X-rays, and he really came upon this by accident. What he had in his lab are these cathode ray tubes, which basically generate energy. If you can think, like I put this picture of an old school, like a boxy TV, they ran with cathode ray tubes. It's kind of like a fancy light bulb. And what Röntgen noticed is that this fluorescent wall on the other side of his lab would glow when he turned on his cathode ray. It was accidental. The painted wall was for something totally separate. But what he found is that screen, right, that painted wall, was responding to an invisible type of energy that no one had really identified before, and he called them X-rays. And what we're talking about here is this radiation kind of hitting a film, right, hitting this what we call photosensitive surface to produce an image. And any structure between the source of radiation and the film will block some of these rays and cause basically a shadow to appear on that screen. So here's a good picture of what we're talking about here. You got your X-ray source. They're running this way. If you put your hand in front of it, your hand will block some of those X-rays. And this produces what's called a plain film or a conventional image. This is, classic radiology is just X-rays. And honestly, for, like I put here, about 100 years after Röntgen, so until the 1990s, they used true films, right? You had to stand in front of this machine, and then you'd get a film, and you'd have to develop that film. We're talking like old cameras, right? Develop that film in a dark room with chemicals, and then you'd form these pretty large images, and we'll look at some in class. These big pieces of plastic, basically, that then you could look at. But this was tough because this required space for development. This required a lot of physical storage space. And it put us in a weird spot because sort of as medicine evolved, realized that you had an X-ray and it was just this one physical hard copy of that picture. So if you had an X-ray taken here in Louisville and then you went to college somewhere else, we'll just even say in Lexington, and you had something happen down there, and you knew, well, I had this X-ray of my knee, a year ago at home, the doctor there would have to try to request and get that X-ray mailed to her or something. That just didn't work with kind of where we are today. So eventually we were able to convert X-rays into digital radiography, right? Just like photography. So now you get X-rays, you get a series of shots. It's all digital. We store it digitally, and then it can be accessed from anywhere by medical professionals. Now what we call this, and this is not something to study, but we call this is PACS, Picture Archiving, Communication, and Storage. It's basically a big server that if you're a medical professional, you can get into, and you can access digital images from really, all across the country or even all across the globe in some situations. Okay, now this slide is back to something that you will want to kind of study, because I'll expect that you guys will know kind of when to use an X-ray, and then also why X-rays are good, but why maybe sometimes they're not so good. So first we talk about applications, so we jump down here. Basically X-rays are really cheap and easy to do. So any kind of initial image where we're wanting to look at the skeletal system, we're going to use an X-ray. We also use these oftentimes to do chest scans initially, and sometimes abdominal scans, depending on what we think might be wrong. Now, X-rays are good things because they are cheap, like I said, and because today the equipment is pretty simple, and so it can be mobile. You can basically take an X-ray machine anywhere you go. Now, the sort of cons of X-ray is that you do have a limitation in what you can see, and we call it a limitation of density, and we'll come back to that here in just a moment. The other problem is that this is radiation, right? And so, we don't necessarily want to irradiate anyone because we could cause mutation, we can cause cancer. Now, X-rays give us a tiny, tiny amount of radiation. So if you've had an X-ray before, don't be afraid. But we wouldn't want to give people a lot of X-rays, right, if they had some sort of chronic condition, because eventually that could build up. A couple of basic images here, and we'll look at more later. Here's an X-ray of the wrist and hand right here. Notice it's really hard to tell whether you're looking right or left, so usually we have some sort of marker. So this R here tells us this is the person's right hand. We've got a chest X-ray right here, and big rule of radiology is that you're always looking at your patient face to face. So that means in this image we don't really need markers. We would know this is the right and this is the left because we're looking at this person face to face. And so you can kind of see some cool stuff here, right? You've got the vertebrae here in the middle. You got clavicles here on either side. Scapula on either side, the shoulder blades. You can see the ribs there. You can see the outline of the heart right about here, and those major vessels. This is kind of where the diaphragm cuts in. But the reason that this is so white is that we do have the liver right underneath there, which is a really dense structure. Then this last one is what we call an abdominal plain film. So plain film of the abdomen. Notice that you can actually make out some of the intestines in here, kind of like this weird stuff in these areas. It looks like they've got a lot of stuff going on here in their colon. But also, pelvic bones here. It's the top of the femur here, and again, this does have a little marker for us, but if we're looking at this person face to face, we would know that this is their right leg and this is their left leg. Okay, now, when we talk about X-ray, we talk about 5 basic densities, and as I said a minute ago, we're very limited in our densities with X-rays. In other words, we can't see a whole lot of refined detail when we look at soft tissues, because your soft tissues all have a very similar density. Where we can see detail is when there's a big difference in how hard something is, right? Its density. So that's why bones show up really well in X-rays, but you don't really see the skin at all or the muscle, because skin and muscle and a lot of those internal organs, they have a very similar density to each other, so the X-rays kind of go right through them. But the harder something is, the more likely it is to block or absorb those X-rays. So a bone would block or absorb a lot of X-rays, and you wouldn't end up getting those X-rays to the screen, and you end up with an image. Now, the more something blocks the X-rays, the more opaque it is, or on an X-ray film, the more white it will look. So something like air, right? Air absorbs basically no X-rays, so it would turn out black on your image. And then we have this range of density. So, least density here, most density down here. You really have 4 natural densities, right? Air, then fat is not very dense, so it's very light gray. Fluid or soft tissue gets a little bit more, fat is dark gray. Fluid or soft tissue gets a little bit lighter. Calcium is your bone, so this is the most dense naturally occurring material, so it's going to turn out white. And then metal blocks all X-rays. So metal is pure white. Now, obviously, metal is not naturally occurring within the body, but if you look at this picture, we got a bullet that shows up pure white. We'll talk later on about biomaterials and things that might be surgically implanted, like metal rods. They'll show up pure white as well. Now, what is CT? Now, CT stands for computed tomography. And this came about in the 70s, so, going on 50 years ago now. What this does is, we call it a rotating gantry. It uses a number, basically, of X-ray machines that rotate around the body so that we can take a whole bunch of X-rays quickly, and then a computer will compile those X-rays into a better image, so to speak. So you basically get this spinning set of X-ray beams and detectors. And what it allows us to do is sort of like digitally slice the body. Right? And so this is a lot harder, I think, to wrap your head around than what an X-ray comes out like. We've got this little video. I'll probably show it in class because I don't think it's just YouTube. I think you kind of have to have access to it. That kind of shows what a CT machine looks like if you were to take the cover off of it. So it's just kind of interesting. But basically, the computer can generate these slices, and so then what you can do is you can kind of almost scroll through the body. So this, again, is tough to imagine, and you really have to have a good idea of what the internal anatomy is. So you're going to have to kind of close your eyes, really picture the inside of that mink that we worked with to try to make sense of this. So what we're looking at here, right, up in this image, is a CT scan of the upper abdomen. So we're just below the diaphragm, right? And what we can think of here is this is like a person laying on a table. So the table would be down here. All right, and so then, like it said there, this is that person's right, and this is their left. So we're kind of standing at their feet, and we're looking up at their body from the foot of their table. But what we've done is we've sliced them. So this is like somebody took an axe and sliced this person right across their stomach, or right across their diaphragm. And so what we're looking at here, although this sounds terrible to say, is we're looking at like this stump of their body laying on this table, right? And so what you can start to see then is little details. So like here is the very outermost part, so like their skin going around, right, their body here, and then you got a little layer of fat, and then you can see these really white things. These are bones, right? So we see their ribs as though we've sort of cut through them, right? And we've got some muscle attached to that. Then if we go inside there, right, we've got their stomach, and the white part is stomach contents, so some food and stuff, so it's a little more dense. But since they're laying on this table, that stuff has sort of settled, and we got this space here, which is just some open gas. Same in these areas where things are black, right? Is that we've got some space there. Now other structures inside here. This is part of the liver. You know, as you see the labels here, this is the gallbladder right there, tucked in the liver. A couple of our vessels we've learned. This is the abdominal aorta. This is the vena cava, so the inferior vena cava. Got a little bit of pancreatic material here. Got the spleen coming over. All this stuff that they don't have labeled. So this kind of area here, here. These are pieces of intestine. Right, small intestine probably coming through. Here would be a vertebrae, so backbone. All right, it says muscle out here, muscle out here. These are really hard. You know, it took me a long time in my first year at med school to start understanding CT scans. So we'll look at some of these, but we'll mainly focus on X-ray. To the right, we've got a CT scan of a little, a different angle. This person we've quote unquote sliced from head to toe when we're looking at it from the side. So got a really cool image of the lower part of the spine here. And again, we've got some of those internal organs. So, here's, this is probably part of the liver here and here. These dark spots are actually intestinal material. Here's the colon coming down in this area, and then the rectum at the very end of it. This would be the urinary bladder right there, and pelvic bone here. So cool, but very hard to kind of wrap your head around. Now CT is fully digital, right? And so as technology has improved, even though these are technically X-rays, we've been able to apply some software and do some cool stuff. So here's some 3D rendered images, or a 3D rendered image of the rib cage and shoulder blades and sternum and heart in here, that comes from a CT scan. So we start with something that's kind of like X-rays, but a computer, we can morph that into a cool 3D image. Now these are, basically like X-rays to start with, though. So most, densities are going to look the same. Got a little better range of density in CT than we have in X-ray, but not much. But two, CT scans can also be post-processed. So because this is all a computerized thing, what we say is that you can do some windowing to a CT. So for instance, in this picture, we've done a CT of the head, and what we're looking for is a stroke, and we're concerned that this person is bleeding. Well, what we can do is, even though it normally wouldn't look this way, we can basically ask the computer to turn fluids a certain color. And so in this case, this is indicative of a bleed in the brain, and it allows us to very quickly know that this person has that problem. All right, so another kind of pros versus cons slide here for CT. You can get CT almost everywhere. It's very rapid, just like X-rays. It's a little bit more expensive than X-rays, but still on the less expensive side if we need to do a scan. Totally digital. And this does expand the gray scale, so we got a little bit more difference in density than we have with X-rays. Disadvantages here, this is large, expensive machinery, so you're not going to see these moving around everywhere. CT scans are pretty much only going to occur at a doctor's office that is a radiology practice or at a hospital. And this is still radiation, so this is still X-rays. So this can also lead to mutation and things. Applications here: abdominal scans, really quick head and brain scans, and then trauma. CT scans are quick, so if we need to know if something's wrong with someone on the inside, but we need more detail and better info than an X-ray can give us, we would do a CT scan. And so in some kind of traumatic injury, CT scans can tell us a lot about what's going on inside the head or inside the body. All right, and then the last one we're going to get into is MRI. And I'm not going to expect you to really know how MRIs work. This is some detailed physics that I don't even know all of. But basically, this is the newest type of scan that we're going to talk about, and this is the most detailed type of scan that we're going to talk about. So if you need something with a lot of cleanness, if you need a really good image, then you're going to go with MRI. MRI uses magnetic fields. And basically what we're doing is we're manipulating the body's hydrogen atoms, which sounds crazy. So this is a lot of like physics and chemistry to make sense of this. If you can think real quick about a hydrogen atom, right? A hydrogen atom is just a single proton. And because of the sort of chemical structure here at that molecular level, a hydrogen atom forms its own little tiny magnetic field. Well, that means you're made up of like, trillions and trillions of mini magnets. And if we were to put a big magnet outside of you, we could actually make those magnets sort of align and sort of manipulate how they are moving. And so what happens is an MRI machine is a big magnet, and it kind of like turns magnetism on and off, which causes your hydrogen atoms to align and sort of excite and then relax back to a different energy source or energy state. And the machine can detect that change. So I know that's crazy deep. Don't worry, you don't have to explain it. But that's what's going on in this machine. Now, because MRI is not, shooting you with energy, but rather sort of messing with and detecting changes in your molecular composition, we can get a really detailed image of any kind of tissue. So hard ones and all those soft tissues of your body. And so MRI can give us a lot of stuff. Its kind of simplest use is to come up with these two-dimensional slice-like images like we would see in a CT scan, or we can use MRI to form 3D images as well. MRI is used a lot in neurology because we can get a better look at the brain and spinal cord with MRI. MRI is used a lot in orthopedics, so surgeons who work on joints, because they're going to give us the best look at your ligaments and tendons and muscles and things around a joint. MRI can be very difficult to tell what you're looking at because it offers us so many different viewpoints. So we'll look at some just sort of at face value, but I won't expect you to get into a whole lot of MRI work. This is the knee, a lateral image of the knee here. So this would be, the lower part of the femur. Like it says here, I guess it does have labels. This is the top part of the tibia. This is the top part of your fibula. But what makes MRI great here is that you're not just seeing these bones, but you're seeing these muscles. So check out, here's a muscle, and we can actually see where it comes up and connects right there. It shows you, you've probably heard of your meniscus before. You can actually visualize the meniscus here in that joint. You got other connective tissue in different places here too. So it allows us a lot finer detail of things. If we jump down here real quick, these are more images of the knee that you could do with an MRI. So these are, obviously different viewpoints. This is looking at the knee sort of like we've cut the leg off almost. So we've got, the femur here, we've got the patella here, and what they're indicating is that this is a little bit too tight, right? There should be more connective tissue cushioning there. So this person has probably some kind of wear and tear injury. And then here's a look kind of from the front of the knee, but sliced. So the the kneecap is gone. We're deeper than that, and we're seeing again. Here's the head of the femur. We're seeing the top of the tibia here, and again we see we can see this joint space and things in between. And here's an MRI of the head, which is cool. And we can see a lot better. I don't think I have to tell you that's the head, but you can see so much better detail. You can see all these details of the brain, which we haven't really gone into brain anatomy much, but you can see the different portions here is the brain stem and all this kind of cool stuff. You can see the sinuses much better in this area too, and things like that. Now, there is one thing about MRIs that I will expect you guys to know, because it's one of the earliest things you do learn in med school about radiology. And, that is a little bit about sort of the post-processing of MRIs. We say that there's two ways to weight an MRI image. You can weight them T1 or T2, and I'm not real worried about knowing what that stands for. But basically, any doctor needs to be able to look at an MRI and know right away if it's T1 weighted or T2 weighted, because different structures are going to look different depending on how it is weighted. In other words, they're sort of opposites. So on a T1 image, water or fluid shows up dark. So we say that water is T1 dark. But on a T2 image, water shows up bright or white. So we say that water is T2 bright. So when you look at an MRI, what you look for is a place where there should be fluid. So there are certain areas of the brain where we see cavities and we see cerebrospinal fluid, also around the spinal cord as well. Or if it's an abdominal MRI, we could look for the urinary bladder, where we would expect to see urine. This allows us to know if it's T1 or T2, because if this fluid-filled space in the brain is black, we know it's a T1 image. If the fluid-filled space in the brain is white, we know it's a T2 image. Now, you might still be asking, well, why does it really matter? Well, because we might be looking for some other thing and trying to figure out what kind of pathology it is, right? What the problem is. Now, I don't know if this will really help you or not, but when I was in med school, they told us to remember this, right, which is kind of hokey, I think. But you are very bright if you notice that the number 2 is found in both H2O and T2. So, in other words, a T2 image has water that's bright, right? Now, here are T1 versus T2 images. So, if we look right in this area, this is where the spinal cord is. Right? And what you notice is that in one image, it is basically black inside that circle, and in the other image, it is bright white. Well, that's the difference between a T1 and a T2. Right? So, in this T1 image on the left here, you get dark fluid. On this T2 image here on the right, you get bright fluid. And we know that by looking at that cerebrospinal spot. Now, normally, in real medical practice, they're going to tell you if it's T1 or T2, but they always make you learn how to tell without that at the beginning of med school. Again, why do we need to use this stuff? So check out this picture on the right. And circled in red here, I've got a pathology, a problem in the brain, right? A growth. And the question becomes, is that a growth that's solid, which would indicate probably some kind of tumor or cancer? Or is that a growth that has fluid inside, which would be not quite as concerning as cancer? Well, if we look at this MRI, here in the middle is it's called a ventricle, right? An open space of the brain that has fluid in it, right? And since this fluid here is dark, that means this is a T1 image. So now, if we look at our pathology, in a T1 image, fluid is dark, and this is not dark. All right, this pathology here is bright. So that means that this is solid, and that this is potentially a cancerous growth, some kind of tumor. All right, so we'll practice this. We'll talk about this more, but the main thing you're looking for is, where are my fluid-filled spaces, like here, and does my pathology match that or not? If it matches, then the pathology is also fluid. If it doesn't match, then the pathology is solid. All right, and so then to wrap up MRI technology, we got our pros and cons. This is the best resolution we can get, the most detail we can get. So this is a great scan for that reason. There's also no risk of radiation. Right? This is just magnets. So usually we see fewer side effects from any kind of MRI imaging. And just like CT, totally digital, easy to look at on a computer. Now, what are our cons? Well, this is really expensive. Right? MRI being this, best image, as you might guess, is also the most expensive thing. You need a big machine that's really expensive. You got high operating costs as well, and so it becomes a problem. Second thing is, if any of you guys have ever had an MRI, you got to go into a tube. In fact, you might have seen things before called open MRIs, which try to help with this. But if you don't like closed spaces, it can be rough. And then the third one, which is sometimes kind of funny to talk about, but it is actually a serious problem, is that this is a giant magnet, right? So any kind of metal that goes into that room is a risk, because the machine will pull that metal to it. Now, why is that a problem? Well, let's say you accidentally leave some scissors on the counter in the room. They will literally fly off that counter across the room and smack and stick to the side of the MRI machine, right? Now, that's scary enough to get impaled by a pair of flying scissors, but think about if you have something metal inside your body. An MRI machine would literally rip it out of your body. So if you put someone in an MRI that did have a bullet fragment inside their body, it would almost shoot them in reverse. It would pull the bullet fragment out of their body, potentially. And this is true of things like pacemakers or surgical staples or things. So you always have to be really careful and not allow any kind of metal objects in there near an MRI machine. Where do we use this the most? Like I said, a lot of neurology, so looking at the brain and spinal cord, looking for muscles, tendons, and ligaments, so a lot of joints and sports injuries and stuff. Okay, so let's look quickly then at some classic films, some X-rays. In class, we're going to do this some more, and we'll look at some actual X-rays against the window, so we'll use some backlighting that way. But we'll look at some X-rays here in this PowerPoint too, so these last few slides will be much quicker than everything else we've done so far. Again, in class, don't expect to get a little marker here that tells you what's right and what's left, but always expect to have to tell me if you're looking at something right or left. So again, we're looking at this person in the face, right? So here's their head up here, and so that means that this would be their right side and this would be their left side. So when we look at this chest X-ray, again, we can see the outline of the heart and the major blood vessels here. We can see the diaphragm with the liver underneath. It's very dense. We can see the vertebrae, so the spinal column back here in the background, along with the ribs all coming off of that. We can see clavicle here, right clavicle, left clavicle. The sternum is up here, but it just kind of blends in with what we're seeing behind it. We've got the right humerus coming out right there, left humerus coming out right here. And then we've got parts of the scapula back here. So there's your shoulder blade back there in the background, sort of on these images as well. And then this stuff kind of scattered in here is some lung tissue. If this was thicker, we'd be worried about the mucus, but this isn't bad at all here, so we just know that the lungs are in there. Here's some more kind of cool scans. I got these off the internet, so I apologize that there's this kind of stuff, but just a neat scan of the vertebrae and the neck. But we can also see the mandible over here, bottom of the cranium right there. Again, here's a clavicle in this area. Then we got some knees. Now, same thing. I would expect you to know left and right of knees and ankles without being told. So, when you look at the knee, if you feel your own knee, you're going to feel this knob kind of on the outside, the lateral side. What you're feeling is this fibular head, right? The fibula. Like they got labeled here, these are both knees. You got the tibia, you got the femurs, you got the fibula over here. So then how do we know, and actually patella you can see is sort of an outline there. How do we know right and left? Well, in this picture, they're showing you both legs, but we're looking at this person face to face, right? So this will be this person's right leg, and this will be their left leg. But we can know that even if we just look at one of these. Again, because this fibula is more on the outside. And if we look at that person face to face, we'd know that this was their right leg to see the fibula here on the outside. So here's an ankle. Right, here's the tibia coming down. Here's the fibula. Here's, tarsal bones. You don't have to know details there. But the question is right or left, right? Again, remember, the fibula is more on the outside or the lateral side of the leg. And if you're looking at this person face to face, that means this is their right leg coming down with the fibula on the outside, tibia on the medial or the inside, foot kind of coming out at you, and they would have their big toe, on this side and their pinky toe over on this side. Now, if we are looking at the hand or foot, it's really hard to tell if it's right or left. So I'm going to tell you in that situation. So this is someone's left foot. You can see the bones and stuff going on in there too. All right, here's the hips. Again, I would expect you to know right or left, and here it's just remembering that you are face to face with this person. So if you're face to face, this would be their left hip. This would be their right hip. They got it broken up for you here. Ilium is that big winged portion. Ischium down in this area. Pubis here in the front middle. Really fun word, acetabulum here, which is kind of a little divot in the bone. And then you've got the femurs right coming up and articulating there. Now, what if I give you this picture, right? Again, you're looking at this person face to face. So you would consider this to be their right hip. And again, you can see the femur coming up. You can see the ball there of the femur fitting into the acetabulum on the pelvis. And then, wow, check that out, right? So if I give you this image, again, you would know right away this is the right leg because we're looking at this person face to face. And you notice they've got a major femoral fracture here that's displaced as well. Alright, then we got a really nice clean and labeled image of the right arm. Again, you would know this is the right because you're looking at this person face to face. So here's their right shoulder. So we got the clavicle right there. Got the scapula. Got a lot more detail in these labels than you need to know. Here's the humerus, as they have it labeled. And the humerus comes down and articulates down here with the ulna. You can just barely see the start of it, and the radius right there. Now this would be a normal image. This would be a problem, right? So this is a right arm with a major fracture of the humerus. This is bad enough that you're seeing a lot of swelling and stuff going on in this area that's even showing up on our X-ray. And actually, believe it or not, this is the arm of Miss Nart, who works down in the main office. She did this years ago, actually fell in her kitchen and broke her arm. Now, keeping up the fun, this is actually Miss Nard's legs, right? Just a year or two ago, I can't really remember, she had knee surgery done. She's actually had this procedure done on both knees now, and this is just the first one. But again, when we look at this picture, they've got a marker, but we don't need it, right? We're looking at this person face to face. This is their left leg. This is their right leg. This is the femur coming down, right? This is the tibia, fibula, right? Tibia, fibula. And what you're noticing here is that Miss Nard has had a partial joint replacement. So basically she's had, you notice how white it is, she's had a nice piece of titanium put in here on the femur, and another piece of titanium nailed down into the tibia. She probably had a situation where the soft tissue in between was gone, and you can see it over here. You know, we should have a nice big dark space in between these two bones. What we're probably seeing instead is we're seeing bone rubbing on bone, which can cause a lot of pain. So you go in, put a piece of metal there, and you form a nice little smooth joint instead of that bone rubbing on bone. Like I said, a few weeks later, she went in and had the other knee done as well. Kind of interesting here, her patella is a little bit offset on this knee, which is kind of weird too. All right, these don't belong to anybody that we know, but here's the hand. Again, if I give you the hand and wrist, I need to tell you which one we're looking at. So this is the left hand. Here it is kind of laid flat on the table, so their thumb's over here and their pinky finger over here. Here it is laying on its edge on the table, so here's the thumb coming forward. But we can see the bones. Because this is the side where the thumb would be, that means that this is the radius and this is the ulna. Ulna is kind of bigger up at the elbow. Radius is bigger down here at the wrist. And then this person, again, here's thumb side. So this would be a major break of the radius here, radial fracture. And then you see the other image, how ugly this is. Has the arm all twisted, probably causing a little bit of a bulge here in the skin even with that break. And then the last one, this is just kind of fun. So this is Kaylee Blazes that graduated just last year. Miss Blazes' older daughter, you probably know Emma. Kaylee has pretty severe scoliosis, right? And so you see this kind of crazy X-ray here on the left that shows this this should be straight, and we see this kind of crazy bend. You can see the other bones in here too, though, is cool. Looks like she's probably wearing some sort of hospital gown or something with a clip here that's showing up. But then you've got an after surgery image where she had these rods inserted to try to straighten her back, which I think is pretty successful in this situation, but just really cool, and leads us right into sort of our next topic, which will be implantable materials. And so you can see these super dense metal rods that are running the length of the spinal column here. All right, so I know it's a lot, but hopefully this is interesting for you, and we'll carry on and continue looking at more of this stuff in class.